Welcome to AETCM, the emergency medicine channel. Today we are going to discuss about treating convulsive status epilepticus in children according to Resuscitation Council UK Guidelines 2021. Shall we begin, sir?
Yes.
Sir, for initially on starting with the management for status epilepticus.
Convulsive status epilepticus.
Convulsive status epilepticus
in children.
Okay.
It's not for non-convulsive.
Non-convulsive. Here, when the seizures start, we should confirm it is a status epilepticus. If at all it's a status or it's a non-status, if the seizure starts, so we have to confirm whether the seizure it is a seizure or not. We have to confirm the diagnosis, and further we'll have to check for the airway, breathing and circulation. And
normally in UK and all, for this Markham-Oskey or Farkham-Oskey and all, you'll get a scenario in which the pediatrics, suppose a 4-year-old boy had a seizure episode at home, and the parents would have called the ambulance, and then the paramedics will arrive at the situation, and then they'll do the needful. Their part they'll do it. Suppose they think that it is a seizure episode, they would have given one dose of benzodiazepine or whatever they would have given, and then they will shift to the ER via the ambulance. In the meantime, they will be informing the ER that so and so, the details about the child and all, whatever they have given, what time they have given. Okay, so in that time, you should be preparing yourself. Okay, you should prepare your team. You should prepare yourself. What all things you are like. Okay, so first of all, you introduce yourself, understand your team, assign the task to your team. Like suppose you are taking care of the airway, I'll assign you the nurse. Suppose you take care of the airway and prepare all airway equipments. And if you are nurse too, I'll assign you a task. You prepare all the circulation equipments plus the drugs, everything. Okay, and everything should be ready before arrival itself, and I'll assign you to prepare the wet flag. Wet flag means weight, energy, tube, fluids, lorazepam, adrenaline, glucose. It's a mnemonic. So depending on the child's age, you should be ready with your wet flag. Okay. Then only you'll be able to stabilize child. All of a sudden, if the patient comes to you, you'll be in a panic state. You won't be prepared with anything. Okay, so preparation is very much important. So assign the task properly. Everybody should know their roles, and everything. Drugs should be ready. Intubation set. Everything should be ready. What is the joule to be given? Everything should be. So prepare the wet flag. Okay, and then suppose your intubation equipments also, everything should be ready. Suppose you are not able to get a patient airway, if you esophageal airway, if you are not able to get, should be ready with your ambu bagging. Then if the ambu bagging fails, you should be ready with your ET tubes, appropriately sized ET tubes and everything. Okay, so this particular case, suppose it's a 4-year-old child. Okay, he started throwing seizure at around say 12 o'clock.
Okay.
What to do now?
So, according to the UK guidelines, so a status epilepticus is a condition where there is a continuous seizure for more than 5 minutes, or else
convulsive status epilepticus.
Convulsive status, okay. Or else we are having multiple seizure episodes and the child is not regaining consciousness in between the seizures. So here the child has got a seizure like about 12 p.m. So if the child has been if the child got the seizure, you have to initially start with airway, breathing, circulation, management of airway.
You should wear your PPE, everything. Okay. Suppose the child threw a seizure, suppose like he's in the ambulance, he threw a seizure inside the ambulance 2 minutes back. Okay. Or I'll say it's 7 minutes back.
7 minutes back. So
okay.
Initially the
and 5 minutes back, the paramedics team gave him a shot of
benzodiazepine.
benzodiazepine, and he arrived at to the ER at 12:05. Okay. Now what?
So if the child has got the first dose of anti-epileptic like midazolam or lorazepam, according to the UK guidelines, we can give midazolam or lorazepam. Midazolam is given like 0.3 to 0.5 mg per kg.
It's not like that. The child has come to you. You have taken the handover from the ambulance. You know that the child has been given the drug at 12 o'clock, suppose.
Okay.
Okay. You're taking inside. Okay. Then you should what? Take to a cot, do a manual inline stabilization. Okay. Then
As that they have given the first drug, so we have to give if the child is continuing to have seizure, we'll have to give the second drug. So we can give the second drug in like.
But there should be a line, right? You haven't placed the line.
So first drug has been given by the paramedics. So a line will be there.
A line will be there. Yeah.
So we can give the drug through that line, and also we can put another line, and we can get the blood which is needed for the other investigation, like electrolytes can be done, and also glucose can be checked.
Okay. Suppose there is no line. Patient straight away came to you.
So we can give.
And no drug has been given. Like suppose 12 o'clock started. 12 o'clock started. Then 12:05 the patient reached here.
So we can give midazolam either buccally, or else we can try with IOSS for lorazepam.
That is but airway and priorities for ABC and all. No, patient is fully conscious. ABC is the priority. So patient has been taken inside. You do a manual inline stabilization. Okay. And then if still it is not the airway is not patent, you go for look, listen, feel. See if the airway is patent or not. Suppose the airway is patent, you apply NRBM with high flow oxygen. Okay. Then you move to B.
In breathing, you have to check for the.
Or else you can, if the patient is still throwing seizure like that, still throwing seizure, mouth is too much of closed, you can turn him to the left lateral side. Okay. Keep some O2. And still, if saturation is not more than 94%, you can actually place a
nasal airway.
Because oral airway you can't place because he's seizing, right? You place a nasal airway and make sure the saturation is more than 94%. Got it?
So after managing with the ABC,
if it is not this thing, if the saturation is still not more than 94%.
nasal
and suppose the respiratory rate is also less than 12,
so
then you can do a back valve mask ventilation. Okay. So by that time you are actually taking care of A as well as
B
also. So move to B. Check for RR and SpO2. Grossly, if saturation is more than 94%, and RR you are like controlling with the back valve mask. Otherwise, if it is spontaneously breathing, respiratory like RR is between 12 and 20 means that much of a respiratory rate is fine for that child. Okay. Then RR and SpO2 is fine. Then B, what are the things?
Then air entry,
inspection, palpation, percussion, auscultation. The neck as well as the chest. Okay. Is the trachea central? Or the neck veins dilated?
Or not?
Inspection wise, is the chest moving equally? Basically, we are in this thing, inspection. Chest wall is moving adequately.
Retraction.
Palpation, is it moving equally? Percussion. Then auscultation. So if everything is fine and RR and SpO2 is fine, B is taken care of. Okay. I'm talking about if you don't have a line right now. Okay. Buccal also you can't place because suppose it's seizing, right? Okay. As quickly as possible, you should be finishing AB and then straight away move to C. See, if the cannula is already placed by the ambulance, like the paramedics, through that cannula itself, you would have already given. Before even starting A, you would have given the second dose of
either
benzodiazepine, lorazepam or whatever you would have given. But now you don't have a cannula here. In C, you will be placing a cannula. Okay. And then, in the meantime, you will be checking for heart rate, BP, CRT, and rhythm. That
Rhythm.
heart rate means it's a rhythm. You monitor your connected. You have exposed the chest, everything. Connected all monitors. Okay. The heart rate, BP, CRT,
rhythm.
Okay.
Rhythm might not be accessible as the patient if the patient is being continuously seizing. It will be difficult.
Practically you may not be able to assess the rhythm because it's jerky movements, everything is there. It will be really difficult to assess the rhythm. But you are not expecting a arrest here. That is a different situation. You are purely dealing with the convulsive status epilepticus. Okay, that's better to confine ourselves to that area because we don't want us to go into that pediatric arrhythmia area because then it will be a full confusion. Okay, so we'll restrict ourselves to convulsive status epilepticus. So heart rate, BP, CRT, then
Rhythm.
Insert
Lines. If line is
IV
not
cannula.
there,
Draw
blood for electrolytes and check for
GRBS.
Okay. And if depending upon the condition, if
what all things you draw blood for?
So if patient can have seizure because of many reasons.
All hematology, biochemistry, blood culture, blood gases, all these things you.
Blood culture also needed.
And also the drugs, because the patient would have, suppose patient it's a known seizure disorder, you would want to know the level of the drugs also. Okay, if it's a it's not adequate level of anti-epileptic concentration is not there in the blood, means naturally seizure threshold will be lowered. So that also you will check, and then immediately you will give a first shot of
benzodiazepine.
Okay, what will you?
So here according to the guidelines we can either give midazolam or lorazepam as the first dose. Midazolam is given in the range of 0.3 to 0.5 mg per kg buccally, or lorazepam 0.1 mg per kg IV or IO.
Okay, so lorazepam 0.1 mg per kg. So you have already placed the buccally. You can't place
As the child is seizing.
Suppose it's seizing. Okay.
So
lorazepam you have given. Okay.
And if the child is
that is at 12 o'clock seizure started, 12:05 you have given
the first
dose of
lorazepam.
Okay.
If the child is continues to have seizure, we will wait for like 5 more minutes. And if the child is continues to have seizure at the time of 10 after 10 minutes, that is means by 12:10 to 12:15, we can give another shot of lorazepam.
Okay. Once after giving the first shot of lorazepam, after 5 to 10 minutes you will be reassessing.
Yeah.
Okay. Then you will be giving the second dose. Okay.
So
second dose how much?
Second dose 0.1 mg per kg IV.
Right. Okay.
So and we will reconfirm epileptic seizure is there, and we will prepare for the second line agent of choice for us that will be given in the next step.
Okay.
So the second line agent is given after 5 more minutes. That is
suppose at that point you took this thing blood for GRBS. GRBS is low. Suppose it's 30. What will you do?
So we have to give dextrose.
Okay. How much of dextrose you will give?
We can so here our aim is to maintain a glucose of 4 to 8 millimole per liter. That is 72 to 90 milligram per deciliter of glucose. If the child is having
4 to 8.
4 to 8.
8 is not 90. 6 is 90. 8 is much more than that. Okay.
So I have to maintain a glucose
like
above
120, 130 that range. You can check. Conversion from millimole per liter. 4 to 8 millimole per liter is the target. And correction should be initiated if it is less than 3 millimole per liter. That is what? How much?
54.
54. Less than 54 milligram per deciliter only you are supposed to
correct
in pediatrics. Okay. So what will be this thing? Will you give 25% dextrose, 50% dextrose, whatever? 10% dextrose is given. That is 2 ml per kg. As per the wet flag. Because wet flag we have already, what? As per wet flag only you are told lorazepam 0.1 mg per kg. And for this glucose also it's 2 ml per kg of 10% dextrose. Got it, no? Okay. So you have corrected that part. Then?
So if it is due to hypoglycemic hypoglycemia induced seizure. So we have corrected the glucose and we'll check for whether the child is continues to have seizure or not.
Then you will move on to the
Second line agent.
Okay.
So second line agent is given at the
maximum like 2 doses of benzodiazepines will be given. One loraz 0.1 mg per kg is 12.5.
Then the next one
Then after
12:10 if we are giving 12:10.
Yeah.
And if
12:10 to 12:15.
12:15. If the child is, if we given the second drug at 12:10 and if the child is continues to have seizure for the next 5 more minutes, we will give the second line agent. Like if we like 12:15 p.m. we will give the second line agent. So we can give levetiracetam at a dose of like 30 to 60 mg per kg, which is given over 5 minutes. And this will be maximum we can give 3 gram, or we can give phenytoin at 20 mg per kg by slow IV infusion over 20 minutes. Or else we can also give phenobarbital, that's given
that is with this thing ECG monitoring.
ECG monitoring,
phenytoin
because
should be given with ECG monitoring. It can cause arrhythmias. Okay. Can cause bradycardia, asystole and all these things. Okay.
And also phenobarbital 20.
Why will it cause phenytoin?
Class 1 antiarrhythmic agent.
1B, I think 1B. I think so.
Then phenobarbital can also be given 20 mg per kg IV infusion over 5 minutes.
Okay. The second line options, you have got three options. 3 drugs. One is Levipil, levetiracetam. Then you have got phenytoin,
phenobarbital.
Or phenobarbital. Phenobarbital. 20 mg per kg. And that is also given by 5 minutes. Levipil and phenobarbital over 5 minutes.
And
phenytoin over 20 minutes.
So here 2 drugs are by 5 minutes and the other one is over 20 minutes. And if we given the second line drug at 12:15 and if the drug is over 5 minutes infusion, so we will get like about 20 minutes over 5 minutes infusion. And if and for that of phenytoin we will give like 20 minutes. And
that means either if it is a Levipil or phenobarbital, after 5 minutes you reassess. Whereas if it is a phenytoin
will
be reassessing after
20 minutes.
20 minutes. That means it will be around 12:40 p.m. I don't know. Okay. Otherwise it can be reassessed at 12:20
p.m. Yeah.
Okay.
And if like about after 5 minutes of that 2 drugs and 20 minutes of the phenytoin, if the child is continues to have seizure, we will call anesthetist and PICU. And
even before arrival, like even if you get a call from the paramedic in the beginning preparation itself, it's better to call the PICU and anesthesia team. Suppose it's a thing, so you should be prepared. So rather than this thing early, informing those guys earlier is better. Okay.
So
in Indian setup and all, we are in a position to intubate and all as per the the UK guidelines, intubation and all these things in such a case may be done by an anesthetist. Okay.
And we will ask already suggested we will reassess after 20 to 40 minutes according to the drug we have given.
Okay.
So in that time, if the child is continues to have seizure, we will prepare for deeper anesthesia with intubation and ventilation, and we'll while preparing we'll proceed with the next step, that is we will give third line agents. Third line agents include
after the second line agent, the first dose of second line agent, you call the PICU anesthesia, and then if your intubation set everything is ready, you can straight away go and intubate with rapid. You can do a rapid sequence intubation either with thiopental or propofol. Okay. Or ketamine and midazolam can also be used. Okay. Depending on the situation, you can do. But if your intubation everything is not ready,
we can give
a additional second dose of second line agents. Okay.
So here the dose for
Levipil, phenytoin or
phenobarbital. If you after intubation, here the doses are like if you are using thiopental sodium 4 mg per kg IV is given, whereas propofol is given 1 to 1.5 mg per kg IV, and ketamine and midazolam also can be used as alternatives. And after intubation we have to monitor for the neurological any abnormalities, and also we can also try with EEG. And after the child is intubated, we will look for further version.
Then again you reassess the ABCD. Again,
So
we
we'll-
reassess the ABCDs to see if the child is not intubated also. Reassess the A, see if it is patent. If not, as reassess the B, then reassess C,
See.
then D. D means D. What all things?
So as it is a child, we will go with the output scoring.
Yeah, if it was an adult, we would have gone with the
GCS.
GCS, GRBS, pupils, and the lateralizing signs. Because it's a child, we have opted for the AVPU scoring. Whether the child is alert,
Verbal response
is there,
painful stimulus or unresponsive.
unresponsive. Okay. Then GRBS, repeat GRBS, because we want our target to be between 4 to 8.
4 to 8.
Then
On reassess,
pupils
should be checked.
The lateralizing signs. Okay. So practically speaking, once you would have either the after giving lorazepam, child will be sedated. So you will not be in a position to assess the GCS by that time. Okay. Or else patient will be, if not seizure is not getting controlled, the patient will be intubated. Okay. Intubated and paralyzed. Then also GCS you won't be able to assess. The lateralizing signs, that also it's not possible because it's already under the influence of the drug. Okay. Then exposure wise, temperature.
Temperature.
Maintain
temperature.
temperature. If it's a febrile seizure and all, no. If its temperature is high, you can give one paracetamol. When it comes to E. Okay. So in a febrile seizure and all, you are not straight away supposed to go and put a paracetamol, like as per the guideline. Okay. After A, B, C, D, E. When it comes to E only, you will be addressing the temperature. Then rash. See if there is any rash or anything in exposure, and then cover with this thing, cloth. Then finally you can hand over the child to the PICU on call. Say so and so patient through a child, 4-year-old child through a seizure at around VTCS at around this thing, and first 2 doses of lorazepam was given, and then seizure wasn't controlled. Later on we gave second line agents, phenytoin or whatever. 2 doses were given, still not controlled. We intubated the child, given propofol. Now seizure is controlled. Now we are handing over the patient to the pediatrics PICU team. The rest of the things will be coming under secondary survey. The ample history as well as the systemic examination. It's not head to foot examination here. Okay, because it's not a trauma case. Okay, so you can say ample history, and whether there was any drug default or anything of that sort, you can. So if it's a known seizure disorder, whether there is any sort of drug default, or if the patient has consumed some seizure-inducing drugs or anything, you can, from the history itself, you'll be able to make out. If it's a poisoning case and all, then only you'll be able to assess. After finishing your primary survey, after everything is stabilized, only you'll be able to know, because history will be taken in the secondary survey only. Or else you should get some clue from the paramedic team as to what the child would have consumed and something of that sort. Okay. Then later on, the later part of the management will be done by the pediatrics department. Okay.
Thanks.